طيب. بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to this innovative idea, Midad, the platform for continuous education for residents in ophthalmology. First of all, I'd like to thank very much the 6th of October University for the great idea. And it's a great honor for Sinjab Academy and for me personally for the collaboration between Sinjab Academy and this esteemed university. Of course, I would like to thank as well Professor Mustafa, Professor Nermeen, and all the team for the wonderful program they are going to present through this platform. And I hope that it will be like a core of more and more collaboration for continuous education. I leave you now to enjoy the presentation of Professor Mustafa Al-Manhali. Of course, Professor Mustafa Al-Manhali, he is a professor of ophthalmology in 6th of October University Ophthalmology Department. The stage is yours and the microphone is yours, Professor Mustafa.
Thank you, Dr. Singab, and it's our honor and a pleasure to be with you today. So let's share our screen. So you can see my presentation now?
Yes, it is clear, inshallah.
Okay. So it's our pleasure to be with you today, and we are going to share the history of anti-VEGF and biosimilars evolution through the history, and what is in the pipeline, and it's going to be in the near future to treat multiple diseases we have, and they are increasing as an incidence and as a burden in our whole country. So it's a story that was started in the 1940, and it's keeping updating and evolving until the last month. We will see how these anti-VEGF are developing, and they are updating, and what are the recent updates in this field. So to have a clear idea about what we have today, let us have a brief history about the idea of vascular endothelial growth factor that was speculated by Michelson in 1940 that any ischemic tissue will release what is called factor X. And this factor X will enhance the development of new vascularization. So those ischemic areas will have a much more perfusion, and this will help this tissue to keep alive. And this is just a physiological theory that this ischemic tissue needs to be well perfused. So 50 years later, it was found that the bovine, an extract from the bovine pituitary follicles produced a material or a molecule that was called the vascular endothelial growth factor. And 5 to 6 years later, this vascular endothelial growth factor was found and was documented in the American Journal of Pathology that it is the factor X that was speculated or proposed by Michelson 50 years before. And then the idea started to develop. If we block this excess of vascular endothelial growth factor, especially in the oncology field, would that help to control cancer, especially cancer colon? And in 2004 was the first FDA approved drug to treat the colorectal cancer with the bevacizumab or the Avastin that was first developed to treat cancer colon. And that in the same year, it was also approved by the FDA to have what we call the vigatinib or the Macugen for the treatment of the neovascular AMD or the wet AMD. And at that time, the pioneer, Dr. Rosenfeld, was thinking out of the box by that time, and he used the bevacizumab as an intravenous infusion, like those treating the cancer colon. But he was using the drug for every 2 weeks for 3 sessions. to treat the wet AMD. And he funded this open label study for 18 patients with a wet AMD. And the patients funded this study in Pascal Palmer Eye Hospital. And it was the first time to see that there is a drug that can improve the vision and not just to stabilize the vision or to avoid vision loss in the wet AMD. Because at that time, what we had in our hand only that we have the BDD or the photodynamic therapy that was just trying to control if we have a macular large CMV, so to stop those patients of losing vision. And since that time, the idea about the vascular endothelial growth factors and the family of these molecules started to be well known and well understood. And it was found that we have 6 members of the vascular endothelial growth factor, but the most important one is the vascular endothelial growth factor A, which is responsible for the angiogenesis and increasing the permeability of the vascular perfusion or the vascular element in the tissues of the body. Also, as well, it was found that placental growth factor has a role which is less than the vascular endothelial growth factor A, but still it is responsible for an inflammatory condition that we can see in diseases like vascular occlusions and diabetic macular edema, as we will see later. Also, with the development of the ideas and the theories and understanding of how the mechanism of the vascular endothelial growth factor are working, it was known that there are 3 receptors that those molecules work upon. But it was found that vascular endothelial growth factor receptor 1 and receptor 2 are the main key players in the pathogenesis that we see in retinal vascular diseases, especially diabetic macular edema, vein occlusion, and the wet AMD. So they thought if we block these receptors, especially vascular endothelial growth factor receptor 1 and receptor 2, will this help us to stop the stimulation of angiogenesis, which we see in the proliferative diabetic retinopathy when those ischemic areas in the periphery started to produce large and excess amount of VEGF. So if we block this VEGF, we will definitely prevent those patients from the advancement of diabetic retinopathy staging. Also, if we block the receptors type 1 and type 2, this will help to decrease the permeability, which is leading to the macular edema we see in the vascular diseases, including of the retina. So since that time, and this is the timeline since we had the first anti-VEGF in the world, which is the Macugen, and it was produced only to block what is called the vascular endothelial growth factor type A 165 variant only. And by that time, as we see that Dr. Rosenfield tried the bevacizumab in 2004, and it showed that it has a much more blockage effect compared to the Macugen, and it blocks all the vascular endothelial growth factor type A. And this is by logic, it will allow us to have a better anatomical response, and this will be parallel to what we see as a functional response and improvement in the vision for those patients. But since the Avastin and since that time until now, as we all know, the Avastin or the bevacizumab, it is used as an off-label usage, and it is formed of a large, full humanized monoclonal antibody with an important to know the size of this molecule, which is 149 kilodalton. And the importance of this that we will see in the future how they will use the size of the molecule to improve the durability of the drug inside the eye. Then 1 year later, Lucentis or the ranibizumab was introduced in the market, and as we can see, it is just a part of the molecule of the bevacizumab, and it is almost like third of the size of the bevacizumab, and it was thought at that time that minimizing the size of the molecule will avoid systemic absorption of the drug, and hence it will be much more safer for systemic comorbidities like brain ischemia or brain insults or cardiovascular events. Then 5 years later, the aflibercept or the Eylea was introduced to the market, and this was the first time to have what is called a fusion protein, which blocks a large number of receptors working on vascular endothelial growth factor 1 and 2, blockage of molecule vascular endothelial growth factor A, B, and placental growth factor as well. So at that time, we are in year 2011. So we have 4 anti-VEGF molecules present at that time. But before that time, in 2002, when the idea of the anti-VEGF started to appear in the world, so we have what is going in parallel with this, what is called a DRTR.net, and this is a collaboration from the Eye Institute and Diabetic Kidney Institute in the States. And this collaboration was minded just to try evidence-based protocols to test how we can prevent the progression of diabetic retinopathy and how we can treat diabetic macular edema in the era of what we have with the anti-VEGF. And they finished almost like more than 30 protocols in more than 350 sites all over the world, and they are still working, and they are nourishing us with more and more protocols involving all the scenarios that you can think about and you can use in a diabetic disease, whether macular edema or diabetic retinopathy. And I really encourage everybody that is treating diabetic patients to explore all these protocols, and these are the gold standard in the management of diabetic patients. Also, by that time, we have more understanding about the pharmacokinetics, and this is very important to understand nowadays because this is the basics of how to produce an optimum anti-VEGF, because they know that when we inject the anti-VEGF molecule inside the vitreous, it will diffuse to the aqueous humor, and then it will transmit to the systemic circulation, and this will minimize the concentration of the drug inside the eye and give a minimal inhibitory concentration inside the eye, which is the T half-life. So every molecule we have in the market, we just ask about how long this molecule will stay with the concentration that is 50% of the injected molecules inside the eye. So this is what we call the half-life. And all the producers and the manufacturers become tending to say that we have a longer half-life, and this is by default will give a longer durability and a longer time for the drug to work inside the eye. So at that time, when we understand the pharmacokinetics and how those drugs start to work inside the eye and what is the maximum time of durability, so we have to re-inject those eye. So we have to search for an optimal anti-VEGF molecule. And the problem is that we are looking for a drug that will give the least burden for the patient and the doctor with the least number of injections, and you are looking for a drug with the least cost that could be possible. And this could be just achieved only by having a molecule that has a longer duration of action with a high vascular endothelial growth factor binding affinity. So when the molecule blocks the vascular endothelial growth factor present inside the vitreous for a longer time with a high affinity, this will definitely work with for a longer time, and we will need a lower number of injections. So they keep thinking about how we can achieve this optimum anti-VEGF. So they started to think like 10 years ago about dose escalation on the intravitreal drug injection. So we all have the idea that injecting probably the Avastin is in 0.05 milli, others they inject the 0.01 milli. So they are doubling the dose they are injecting in the vitreous, searching for a longer duration of action. Other idea came, and we will see it later in the presentation, increasing the molecular weight of the drug injected inside the eye, which is now called the KSI 301 or the Kodiak drug. And if we compare this drug, it's a large molecule, which is 950 kilodalton, compared to the Avastin, which is only 150 kilodalton. So increasing the molecular size will decrease the systemic absorption, so this will lead to a longer duration of action. Also, they thought about what decreasing the molecular weight, the other idea. So when we decrease the molecular weight of the drug, like what we have 2 years ago, the prolizumab or the Beovu, This was allowed us to have a more number of molecules inside the same amount of injected drug. And finally, we are waiting for the port delivery system, or the PDS, which will introduce the idea of the slow relief of the anti-VEGF inside the eye. And this chamber are refilled every 6 months with ranibizumab to keep releasing the drug inside the eye, and no need for frequent injection every month or every 2 months. But we are still waiting for the phase 3 and 4 of this PDS. So the other burden is the low cost. We are searching for a powerful drug, as we have seen, and with a low cost, because those patients, whether we are talking about a national support in a public service or even in private service, all of those entities are suffering from the cost of re-injecting those patients with a large number of patients, and especially diabetic macular patients, which are expected to increase in the coming few years. So the idea of the biosimilars are starting to appear, just to have a drug with a lower cost. So how do they have this drug with an effective molecule with a low cost? So they started to produce a biotechnological product that is almost similar to in the quality, in the clinical and non-clinical performance of the molecule, and with no other difference in the safety compared to the original molecule, with just a minor change in the structure. So when we search for just a molecule that have the same effect, with the same safety profile, with some minor structure, this will help us to produce a drug that is effective and probably with a low cost. So how they will produce it in a low cost? They just inverted the production hierarchy, as we will see. So if we compare the hierarchy for the originator drug production, so we have some analysis about the structure of the drug. Then we do some preclinical studies, which consume some of the cost or some of the financial support when we are developing a new drug. Then we have the clinical pharmacodynamics clinical trial, just to explore how this drug is working, how this drug is excreted from the body. And this is probably is done in a lab work in phase 1 and phase 2 of the study. Then we have a large spectrum and large time for almost 1 or 2 years, as we see in all peer studies, that we hear about year 1 results, year 2 results about the drug in the clinical studies, and it is done in each separate disease, which we have a drug like the aflibercept studies for the wet AMD, aflibercept studies for diabetic macular edema, others for the vascular occlusion. So all of these studies definitely consume a financial burden when we develop a new drug. In comparison to the biosimilar, this is not the case. It is inverted. So they did an analytical studies just in offices or even in labs for a few times. Then they start to minimize the preclinical and the clinical pharmacokinetic as soon as they find that this molecule is similar to the originator molecule. So since we have a molecule that is almost the same with a minor change in the structure, they started to apply this molecule in a clinical study. And also, they don't do the studies for all the indication. They use what is called indication extrapolation, which means that I will try this new biosimilar for one indication, which is, for example, we can use it for diabetic macular edema. And if it showed a very good response, then this drug will be available for diabetic macular edema, vascular occlusion, and wet AMD. So they don't consume a lot of money to produce the biosimilar. That's why we have a lot of biosimilars coming in the near future with a very, very comparable low cost compared to the originator drug. And probably they will find their way, especially in countries where are supported by a national health system, and they are looking for a low cost. So to produce a biosimilar, you have to wait for the originator approval or patency to expire. And by 2022 to 2025, the three main drugs that we had in the past are starting to expire, whether in Europe or in the USA. So in 2022, we had the first biosimilar from the ranibizumab, which is called Razumab, and this was the first ever approved from the FDA to be used for diabetic macular edema patients and wet AMD. And then the BioViz or ranibizumab Nuna are expected to be FDA approved recently. So those are the approved FDA biosimilars that we are waiting or we are hearing about nowadays. But let's go back a few years. In 2011, we said that we have the aflibercept, but in 2014, there was a molecule which is a biosimilar at that time, and it was the first biosimilar to be introduced to the world, but it was used only in China, and it was called the Conbercept, and it was a biosimilar for the aflibercept, blocking vascular endothelial growth factor A, vascular endothelial growth factor B, and the placental growth factor, which is also blocked by the Eylea or the originator aflibercept. And this molecule was tried in a non-inferiority study called the Sailing study to see if this Conbercept is comparable or non-inferior to the laser for the diabetic macular edema at that time. And it was found that, yes, this molecule is comparable and it is safe to be used in diabetic macular edema when it was compared to the laser. Then we will move later on, 5 years more, which is in 2019, where the pralucizumab or the Beovu introduced in the market. And this is the idea about minimizing the size of the injected molecule using only what is called a single chain functional variable, which is 26 kilodalton. It's almost 1/6 of the Avastin. So in the same amount or in the same volume, when you inject a molecule with aflibercept or ranibizumab, you are going to inject 22 times molecules of the pralucizumab in the same volume if you inject ranibizumab or aflibercept. So this will allow you to have more molecules inside the eye in the same volume, definitely will give you a prolonged effect. And they claim that this drug will improve the bioavailability, decrease the immunogenicity of the drug, better target tissue penetration for the ischemic areas, and definitely will allow a better durability for the disease. And if we compare the amounts of the drug injected, this is the 11 compared to 1 in 11 in the pralucizumab, 1 in the aflibercept, and half in the ranibizumab. So injecting 0.05 of the pralucizumab will be 22 times in concentration compared to ranibizumab. But this turned on after it was shown in Kite and Kestrel studies that pralucizumab or the Beovu is non-inferior to the aflibercept, and the intraocular inflammation is comparable to the aflibercept, but unfortunately this was introduced in Egypt with the VEGF, and it caused all over the world a severe form of inflammation with severe vasculitis, severe retinitis, no PL vision, and probably the drug started to not to be injected anywhere in the world. And for the bad luck, there is a site for the Beovu lawsuit where those patients lost their vision or had some sort of inflammation or vasculitis, starting to sue this drug. Then after 2019, and after we finished the hassle of the VEGF or the Beovu, and in 2022 January, we had this new idea, which is the Faricimab, and it is called the power of two because it is the first bispecific antibody which works on two different molecules, the vascular endothelial growth factor, blocking all of them, and blocking as well what is called the angiopoietin type 2. And this molecule, the angiopoietin type 2, is responsible for the angiogenesis and the proliferation of the vascular sprouts when we have ischemic elements inside the eye. And this molecule was tried in the Boulevard and then phase 3 and phase 4 of the Usmet and Ryan study to show in these non-inferiority studies compared to the aflibercept that injecting this molecule, the Beovu, the faricimab or the Vabysmo, which is known name in the market, is non-inferior to aflibercept, and it even much better than the aflibercept 2 milligram because it can extend the durability of this injected molecule inside the eye up to 16 weeks. So you can injecting your patients with the loading dose. You can then inject your diabetic macular edema patient every 4 months instead of injecting them every month. And this is the idea of extending the durability of the drug inside the eye and hence lower the number of injections. And then 1 year later, we have this new idea or this new molecule from Regeneron with the Eylea high dose, which is the 8 milligram instead of the 2 milligram. And this was tried in the Pulsar and Photon trials for the wet AMD and for the diabetic macular edema. And the difference in this drug that it is injected in a much larger volume, which is 4.07 milli. And by usage and from my experience and different areas of experience and trial, this injection of a larger molecule, of a larger volume does not increase the IOP inside the eye, and you don't need to do a paracentesis. So it is just injected like others 0.05 mil without any additional steps. And when it is compared from the drug producer, it is compared to the 2 milligram, which is by now it is well known safety profile because for now we are using the Eylea 2 milligram for almost 14 years. So comparing this to that, it showed the same safety profile for the 8 milligram as well. And what is interesting in this 8 milligram or the high dose Eylea, that as we can see that in diabetic macular edema, after loading the patient, you can inject more than 80% of your patients once every 5 to 6 months. So you extended your injection time or interval to more than 4 months for what we have in the past. So you can offer to patients in diabetic macular edema that they could be injected almost once or twice per year, and they can keep their vision without the need for re-injection. And also in the wet AMD, we can offer 70% of our patients that needs to be injected frequently, especially in this devastating disease. You can inject 70% of your patient 2 to 3 injections per year, and they are keeping a dry retina with a very high vision. So this is the idea of increasing again the durability of the working drug inside the eye and lower the number of injections. So let's move on to the adverse events. All of us know the ocular intravitreal injection complications, whether the injection site discomfort, subconjunctival hemorrhage, IOP spikes, which is easy relieved even by massage. And it's very important for if you are going to inject a naive patient to tell him that you may see a floaters for 3 to 5 days, because some of those new patients that receive injection get anxious and they don't understand what is going on when they just move after getting their injection inside the eye, and they don't know that this is the drug floating inside the vitreous. Also, you can have the iritis by vitritis, cataract if there is a traumatic injury while doing the injection. And the most devastating one is, as we all know, the endophthalmitis. But what I want to highlight more is the systemic adverse effect of the intravitreal anti-VEGF injection. So this is a brilliant report from the American Academy in the 2018, and it compared like 23,000 patients receiving in 3 arms the anti-VEGF compared to laser and compared to steroids. And on a 10-year follow-up for diabetic macular edema receiving those kinds of treatment, they compared the risk of cerebrovascular insults, myocardial infarction, major bleeding, all causes of hospitalization that could happen within a 6 month of injection of anti-VEGF. And it was very interesting that they found that there is no ever a significance compared in the three arms, and the injection of anti-VEGF didn't even cause any further hospitalization or any cerebrovascular event compared to the other two modalities of treatment. And they found that probably those entered the hospital for any reason, it was a comorbidity and it was not for the injection of the molecule itself. So after introducing the idea of the anti-VEGF and what we are looking for, the anti-VEGF, and what we have in our hands, manufacturers and producers and scientists are still looking for a more and more powerful drug that could be injected with a fewer number of injections. So interestingly, nowadays we have the idea of injecting a gene therapy to deliver what is called a aflibercept or ranibizumab-like protein, which will be with a single injection. You will have a multiple-year relief for diabetic macular edema or wet AMD or even vascular occlusion cystoid macular edema. So these are the idea, and I want just to raise what we will have in the near future about introducing the gene therapy for producing a molecule like the blockage of the ranibizumab or a protein like the aflibercept. It will be produced from our body, and it will block the excess of the vascular endothelial growth factor, causing the pathogenesis in all the vascular disease. Also, there is a molecule which is the KSI or the Kodiak that we discussed earlier. And the idea is, as we can see, it's an ABC. And the ABC is the antibody when it is added to a large biopolymer will form a conjugate, which is a 950 kilodalton. And the idea is to form a large molecule to stay for a longer time inside the eye. And when it is tried in phase 2 and phase 3 trials for different indications, it showed that 82% of the patients in diabetic macular edema would be able to be extended for 3 or even longer intervals between an injection and another. So as we see, all we are thinking about is to increase the intervals between the injections and to have a fewer number of injections. It's a burden for the patient. It's a burden for the injecting or the service offering institution. So if we can have lower number of injections, definitely with very good function and anatomy, definitely this is our goal in the near future. So this is just a summary for the timeline for the production of the anti-VEGF agent since 2004 until what we have in 2023 with the Eylea high dose. And these are the biosimilars that was started in 2015 with the approval in 2021 and 22. This is a report for a new biosimilar that was published like a week ago. And this work was done by the brilliant Ashish Sharma in India using a drug called Osiva, which is a biosimilar for ranibizumab. And in this study, he proved that using this molecule in India as a biosimilar for ranibizumab showed a similar effect with the same safety profile for all the approved indications for ranibizumab when we use this Osiva. So as we can see, the idea started with exploration or with a question in 1940, and it keeps updating and evolving until the last week with new molecules, all of them searching for a lower number of injections with a high affinity, binding affinity, and a longer duration of action. And lastly, I would like and I encourage you to explore this report from the American Academy regarding the intravitreal pharmacotherapy for diabetic macular edema, which will give you a brief idea about what I have said and probably what the future will show us in the idea of blockage of the vascular endothelial growth factor, and the introduction of the gene therapy for the management of the vascular diseases of the retina. Finally, I would like to thank you for your attention, and you will find all our coming webinars on Punjab Academy and on our YouTube channel for the ophthalmology department, 6th of October University. So I'd like to thank you, and I'm open for any question to answer or any discussion. I'm open to. So there is no more questions. It's all thanks. All the thanks for you and for um, that 6th of October University, and definitely for Dr. Sinjab for accommodating us today. And I hope to see you in the upcoming lectures. It will be every 2 weeks on Friday by 8 p.m. Thank you, and see you later. Thank you, everyone. We got a question. Can we load Eylea 2 milligram, then continue with 8 milligram? So regarding loading with one drug and then to switch to another one, there is no a formal protocol for this idea. But there's a protocol called an AC, diabetic retinopathy study, the RCR, called an AC. They started to inject patients with Avastin, then they switched to Eylea 2 milligram, and it showed a very good response and very good anatomical and functional gain. Regarding your question, this is a very early experience regarding the 8 milligram because it's recently in Egypt, almost all 4 or 5 months only. So if you inject your patient with a 2 milligram and you find a very good response regarding the functional gain, this is enough for you to continue with the 2 milligram. And my advice, don't switch between anti-VEGF if you have a very good response, and you have to be patient, especially between the 3rd and the 6th month. So just keep injecting your patient as long as there is an improvement, despite if this improvement is slow or minimal compared to other patients, because the response for anti-VEGF is not the same in all patients. Some are called late responders. So don't switch, in my opinion, if your patient is responding before the 6th injection or the 6th month of anti-VEGF. If your question just tackle the idea, what is the gain if we were using Eylea 2 milligram, then we will inject a higher concentration of the same molecule. This was tried by some people and it showed a good response because increasing the concentration led to a more half-life, and this will definitely imply a good positive response when we increase the concentration for blockage of more vascular endothelial growth factor receptor 1 and receptor 2. So if you have a poor patient on 2 milligram, yes, you can switch to 8 milligram. Thank you. So no more questions. Thank you. Have a very good weekend and see you later. Thank you, everyone.